Welcome to today's deep dive. We are genuinely so glad you're here with us.
Yeah, thanks for tuning in.
So, right off the bat, if you actively track global health trends, you've probably noticed a pretty recurring pattern in the discourse.
Oh, definitely.
The biggest, most daunting headlines usually revolve around, the very frontier of medicine.
Right, it's always novel pathogens or...
Exactly.
Yeah.
Highly complex genetic therapies or these ultra-rare conditions that take decades of incredibly expensive research just to figure out the basic mechanism of action.
Yeah, the assumption is always that the highest hurdles in public health are the scientific unknowns.
Right. But our mission for this deep dive, and this is based on some really eye-opening new data, is to explore a massive global health paradox that completely flips that assumption on its head.
It really does.
Today, we're analyzing a World Health Organization news release from February 11th, 2026, alongside this really comprehensive study published in The Lancet Global Health.
And what these sources reveal is just, well, it's fascinating.
It is. They show that sometimes the bottleneck isn't the science at all. Sometimes the most significant failure in the global health apparatus is simply the inability to deliver a proven, highly efficient 15-minute intervention.
To the exact people who need it most.
Yes.
It's a profound paradox, honestly, and frankly, a deeply frustrating one from a systems engineering perspective.
Oh, I can imagine.
We are looking at a medical condition that affects over 94 million people globally.
94 million. That is just a staggering number.
It is. It causes severe visual impairment and remains a leading cause of blindness worldwide. But the critical variable here, the thing you really have to keep in mind, is that this condition is entirely permanently curable.
Curable, not just manageable.
Exactly. We are not talking about managing a chronic illness with expensive therapeutics for the rest of a patient's life. We're talking about a definitive surgical fix that takes about 15 minutes.
Just 15 minutes.
Yeah. Yet, according to the Lancet data we're digging into today, 1 in 2 people facing this blindness cannot get access to that surgery.
1 in 2.
Half of the global population suffering from this are essentially left in the dark by systemic logistical failures.
When you look at the raw efficiency of the intervention versus the massive scale of the failure to deliver it, it really forces you to reevaluate how we measure medical progress.
It really does.
We tend to celebrate the moment a cure is discovered, right? We just assume the battle is won.
Right. Pop the champagne, the science is done.
Exactly. But for you listening right now, whether you're analyzing public health economics, assessing global infrastructure, or if you're just interested in systemic inefficiencies, this is a textbook case study.
It proves that the logistics of medicine are just as vital as the biology.
And sometimes much harder to solve. So we're going to look closely at the demographic headwinds compounding this issue, the specific modeling from the Lancet study, and the macroeconomic barriers keeping this intervention out of reach.
To set the baseline here, the condition we are analyzing is cataracts. Since you're likely familiar with the medical basics, we don't need to rehash high school anatomy about the clouding of the eye's natural lens.
We can skip the biology 101.
Exactly. What we do need to analyze is the evolving risk profile. The traditional clinical view heavily associates cataracts with the natural aging process.
You know, the gradual breakdown and clumping of lens proteins over decades.
Yeah. However, the World Health Organization report emphasizes that focusing solely on age obscures a much more complex epidemiological picture.
Because when you look at the secondary risk factors highlighted in the data, you realize they are effectively tracking right alongside modern global health crises.
They absolutely are.
We aren't just dealing with aging populations anymore. We are dealing with aging populations that are simultaneously exposed to prolonged UVB radiation, widespread tobacco use, the systemic use of corticosteroids, and surging rates of diabetes.
And that intersectionality is what makes that 94 million figure so daunting.
How so?
Well, take diabetes, for instance. It fundamentally alters cellular metabolism, including within the lens of the eye.
Which accelerates the cataract formation.
Drastically. And as diabetes rates climb exponentially in developing nations, they act as an accelerant on the existing baseline of age-related cataracts.
It's like adding fuel to a fire that was already burning.
Perfect analogy. Furthermore, corticosteroids, which are vital for managing a vast array of autoimmune and inflammatory conditions globally, they also carry a known risk of accelerating this lens opacity.
Wow.
So the pool of patients requiring intervention isn't just growing linearly with age, it is expanding aggressively due to these compounding lifestyle and environmental factors.
Which brings us to the intervention itself. From a clinical standpoint, outpatient microscopic surgery to remove a cloudy lens and insert an artificial intraocular lens is practically routine today.
Very routine.
It's done under local anesthesia, requires minimal recovery time, and provides an immediate restoration of sight.
Immediate. That's the key word.
Just to put that 15-minute surgical time frame into perspective for a second for you, that is roughly the time it takes to scroll through your email inbox trying to find the unsubscribe button for a newsletter you don't even remember signing up for.
We've all been there.
Right. In that exact same window of time, a trained specialist can permanently reverse a person's blindness.
And from a health economics perspective, it is consistently ranked as one of the most cost-effective interventions in modern medicine.
Which makes this whole paradox even crazier.
It does. When you calculate the disability-adjusted life years saved by this procedure, the return on investment is staggering.
Because the cost of the supplies is so low.
The cost of the surgical supplies and the localized time of the medical staff is minuscule compared to the macroeconomic drain of a working-age adult losing their vision.
Or an elderly person requiring full-time caregiving.
Exactly.
So if the clinical side is effectively a solved equation and the macroeconomics heavily favor intervention, the variable that is breaking the system has to be on the delivery side.
It has to be.
Let's look at the actual numbers from the study published in the Lancet Global Health. The researchers didn't just look at a small, localized sample.
No, it was massive.
They analyzed reports from 68 distinct country estimates, specifically covering the years 2023 and 2024. And the historical context they outline paints a rather deceptive picture of progress.
It really does. Because if you only look at the top-line historical metric, you see that over the past 2 decades, global coverage of cataract surgery increased by about 15%.
Which sounds great.
On a surface level, yes, a 15% bump in coverage sounds like public health infrastructure is successfully scaling. But that number masks a severe underlying friction.
Right, because that 15% increase wasn't happening in a vacuum. It was actively fighting against those demographic headwinds we just discussed.
Precisely. The denominator in this equation, the total number of people needing the surgery, was expanding rapidly due to global aging and rising diabetes rates.
So the target was moving.
Fast. So while health systems were physically performing more rapid turnaround lens replacements every year, the sheer volume of new cases meant the overall coverage rate was barely inching forward.
It's the public health equivalent of running on a treadmill that's slowly increasing its speed.
You are expending significantly more energy, but your actual forward momentum is marginal.
And the predictive modeling for the current decade is where the Lancet study shifts from concerning to highly alarming.
Yeah, the projections are grim.
The data projects that coverage for this surgery is only going to rise by about 8.4% over this current decade.
We are dropping from a historical 15% increase down to a projected 8.4%.
The momentum is flattening out precisely at the moment when the aging curve dictates it needs to be accelerating.
And to contextualize how severe that drop-off is, we have to look at the World Health Assembly's stated goals. They are the decision-making body of the WHO, and they set a formal target of a 30% increase in surgical coverage by the year 2030.
A 30% target. And the current trajectory modeled by the Lancet puts us at 8.4%.
We aren't just missing the target.
We are in a completely different statistical zip code.
Absolutely. It strongly implies that whatever incremental progress was achieved historically through low-hanging fruit, like optimizing existing urban clinics.
That's all been exhausted.
Completely exhausted. The current global health architecture simply cannot scale fast enough to meet the compounding human demand.
Which naturally leads to the question of distribution. Who exactly makes up the invisible half of this data?
The 1 in 2.
Right. When we say 1 in 2 people cannot access the surgery, we have to recognize that the deficit is not distributed evenly. The Lancet Global Health Study cross-referenced the demographics of the unseen, and the disparities reveal deep fractures in global health equity.
They do.
Let's start with the geographic data, because the regional disparity is stark. In the African region, 3 out of 4 people who need this intervention remain untreated.
3 out of 4.
That is a 75% failure rate in care delivery. Millions of people in that specific region are progressing toward total blindness, fully aware that a quarter-hour outpatient solution exists.
But they are completely walled off from it by geography and infrastructure.
The regional gaps are massive, but the demographic failures extend beyond just borders. The data explicitly highlights profound gender inequities that persist universally.
This is a huge finding.
Women are disproportionately affected across all regions.
And this is not a localized cultural phenomenon isolated to one specific continent. Consistently, regardless of the overarching health system, women experience measurably lower access to this specialized care than men.
I have to challenge the premise here for a moment, though.
Go for it.
If this rapid turnaround lens replacement is historically one of the most cost-effective interventions in medicine,
Yay.
why is there a market failure of this magnitude?
It's a great question.
Usually, where there is a highly efficient, high-demand service, the private sector or the free market rushes in to capture that demand. Why is a 75% gap in the African region falling entirely on struggling public health infrastructure? Why hasn't this gap been closed by private enterprise?
That is the crucial friction point of health economics. You have to separate macro-level cost-effectiveness from micro-level purchasing power.
Go compact that a bit.
Yes, saving a society from the economic burden of blindness is incredibly cost-effective for a nation's GDP. But the private sector requires a consumer base capable of paying for the service at a margin that covers the capital expenditure.
Right, and the equipment isn't cheap.
Not at all. The capital expenditure for ophthalmic surgery is not trivial. You need sterile operating environments, highly sensitive surgical microscopes, reliable cold chain supply lines for the intraocular lenses.
And uninterrupted power grids, I imagine.
Exactly. The populations most in need, particularly in rural areas or marginalized communities, simply do not have the disposable income to support a private, profit-driven surgical center.
So the free market ignores them.
It becomes an absolute market failure, shifting the entire burden onto public health ministries that are already underfunded.
Which perfectly segues into the structural barriers detailed in the WHO report. It isn't just about the cost of the equipment. It is about the extreme bottleneck in human capital.
Yes.
The primary barrier listed is a severe shortage and unequal distribution of trained eye care professionals.
The human capital deficit is perhaps the hardest to solve. Training an ophthalmic surgeon requires years of specialized residency beyond basic medical school.
They have to master delicate microscopic surgery.
And once trained, there is a powerful economic incentive for those specialists to cluster in urban centers or wealthy capital cities where the infrastructure is reliable and the private pay patient base actually exists.
Which creates a massive unequal distribution.
Right. You could have world-class eye institutes in a capital, while rural populations just a few hundred miles away have absolutely zero access to anyone qualified to hold the scalpel.
And for the patients who do try to navigate this system, they hit the second structural barrier, high out-of-pocket costs.
Even in public systems.
Yeah, patients are often forced to cover the cost of the artificial lens, the surgical consumables, or simply the transportation to the urban clinic.
And for a family living near the poverty line, coming up with the cash for a surgical intervention, even a heavily subsidized one, is a mathematical impossibility.
And if a patient miraculously overcomes the financial barrier and the geographic barrier, they often slam into the third barrier.
System capacity and long waiting times.
Because the demand so vastly outpaces the supply of surgeons and operating theaters, public health waitlists can stretch for years.
And during that holding period, a patient's vision continues to degrade, actively shrinking their world, their economic independence, and their physical safety.
There is a fourth barrier the WHO report highlights, and I found this fascinating because it is entirely behavioral.
Yeah, the awareness gap.
Yeah. It is the limited awareness or demand for the surgery, even in areas where the infrastructure successfully exists.
This touches on the psychology of aging and marginalized communities. If you build a state-of-the-art clinic, the assumption is that patients will flock to it.
Right. If you build it, they will come.
But if a local population has generationally viewed blindness as an inevitable, unavoidable consequence of getting older, they won't even seek a diagnosis.
They simply don't know a quarter-hour fix is possible.
Exactly. Furthermore, this lack of targeted health communication directly feeds into the global gender inequity the data revealed earlier.
How so?
While in many societies, women have restricted access to health literacy, less autonomy over household finances to approve out-of-pocket medical travel, and heavier caregiving burdens that prevent them from leaving their communities to seek care.
It is a perfect storm of logistical, economic, and behavioral friction.
It really is.
But to ensure we don't just get lost in the regression models and systemic failures, we have to ground this in the actual human impact. Dvorak Hestel, the director of the WHO Department of Non-Communicable Diseases and Mental Health, provided a statement that distills the stakes perfectly.
I love this quote.
She noted, Cataract surgery is one of the most powerful tools we have to restore vision and transform lives. When people regain their sight, they regain independence, dignity, and opportunity.
That statement is the linchpin of the entire Lancet analysis. When we discuss this issue, we aren't really talking about ophthalmology. We are talking about human capital and societal architecture.
Exactly.
When an adult loses their sight to an entirely curable condition, the economic ripple effect is devastating. They drop out of the workforce, instantly destabilizing their household income,
And they require navigation assistance.
which frequently results in secondary economic damage, often young girls being pulled out of the education system to serve as unpaid, full-time caregivers for their elder relatives.
The loss of dignity is visceral, but the restoration of it is just as immediate. That is the unique power of this specific intervention.
When that artificial lens is placed, the economic reversal happens overnight.
The caregiver is released back to the classroom.
The adult reintegrates into the local economy.
The elderly regain their autonomy.
Yeah.
We are measuring the return on investment not just in visual acuity charts, but in the immediate restoration of human potential.
Which brings us to the operational phase of the WHO's release today, the systemic solutions.
Right.
The WHO is explicitly calling for governments and international partners to pivot their strategies because we already established that the current 8.4% growth trajectory is failing.
The first proposed solution is the integration of vision screening directly into primary health care. Let's analyze the mechanics of that.
Okay.
Right now, eye care is heavily siloed. It is treated as a highly specialized, separate branch of the medical tree. If you want your eyes checked, you go to an eye clinic.
But the WHO is suggesting we collapse that silo.
Yes. By integrating screening into primary care, a community health worker managing a patient's diabetes or checking their blood pressure could simultaneously flag early-stage cataracts,
It moves the point of detection closer to the patient's daily life.
bypassing the need for them to independently seek out a specialist just for a diagnosis.
However, screening only works if there is a referral pathway that functions. That leads to their second solution, aggressive investment in essential surgical infrastructure.
This is where the free market failure has to be subsidized by state or international funding.
Exactly. Health ministries must build out sterile operating theaters, secure the necessary surgical microscopes, and establish robust, temperature-controlled supply chains for the consumables in secondary or regional hospitals.
Pulling the capability out of just the major capital cities
Right.
and building the room is useless without the surgeon, which ties into the third, and perhaps most difficult, mandate expanding and better distributing the eye care workforce.
Yeah.
How do you actually incentivize a highly trained microscopic surgeon to relocate to a rural or underserved area?
It requires creative public policy. You have to restructure medical training incentives. This could involve debt forgiveness programs for ophthalmologists who commit to rural postings, or investing heavily in mobile surgical units.
Essentially outfitting durable vehicles as sterile ORs that can travel between regional outposts.
Bringing the highest level of surgical capability directly to the communities that lack fixed infrastructure. It also involves task shifting.
Training mid-level ophthalmic nurses to handle the robust pre- and post-operative care.
Yes, allowing the limited number of surgeons to focus exclusively on the high-volume physical act of the surgery itself.
Finally, the WHO report demands targeted efforts to dismantle the demographic inequities, specifically prioritizing women and marginalized groups.
Because a blanket policy of simply performing more surgeries won't close the gender gap if the underlying barriers remain.
Exactly. If data shows women lack the financial autonomy to pay for transport, then the health system must design a solution that absorbs that specific cost.
Whether through direct subsidies or community-based mobile screening camps that eliminate the need for travel entirely.
The intervention has to be tailored to the friction point.
Ultimately, the objective is to transition this intervention from being a geographical and economic privilege for half the world to a universally accessible standard of care.
The technology and the surgical techniques are already perfected.
The challenge for the next decade, if we are to have any hope of hitting that 30% target, is purely a matter of political will, infrastructure financing, and supply chain management.
As we wrap up our analysis today, the core takeaway I want you to retain is this. We are looking at an established quarter-hour procedure that holds the literal power to eradicate avoidable blindness for tens of millions of people.
The biological science is flawless.
The macroeconomic data is unequivocally supportive.
The only thing standing between 94 million people and their vision are logistics, resource allocation, and systemic friction.
It serves as a stark reminder that in the realm of global health, medical innovation is only the first half of the equation. The delivery and scaling of that innovation is what actually moves the needle for humanity.
And to leave you with a final thought to mull over as you analyze these types of systemic bottlenecks in the future.
What are you thinking?
We talked extensively about the friction of primary care screening and the lack of specialists to diagnose the condition. But consider the rapidly accelerating capabilities of technology in your pocket.
Smartphones.
As high-resolution smartphone cameras merge with advanced, locally run AI diagnostic models, how far away are we from an ecosystem where the need for a primary care diagnostic layer is bypassed entirely?
Wow.
If an app can accurately map lens opacity from a selfie in a remote village, it instantly digitizes the awareness phase, shifting the global health bottleneck entirely away from diagnostics and exclusively onto the surgical supply chain.
It forces us to ask how AI might completely rewire the logistical pathways we've been relying on for the last century. That is a brilliant technological pivot to consider, and it completely reframes where public health dollars might need to be spent in the next 5 years.
It's an exciting prospect.
Thank you so much for joining us for this deep dive into the true hurdles of global health and infrastructure. We hope you walk away a little more informed, a little more analytical about the systems around you, and with a fresh perspective on what it actually takes to deliver a cure to the world. Until next time, keep asking questions.